Hi, everyone. Welcome back to another session of IS-PEC Talks. Today, we're delighted to host Dr. Carolyn Steele Gray, a leading scholar in implementation science, digital health, and integrated care. Dr. Steele Gray is the Tier 2 Canada Research Chair in Implementing Digital Health Innovation, a scientist at Sinai Health, and an associate professor at my alma mater, the Institute of Health Policy, Management, and Evaluation at the University of Toronto. Across her work, she focuses on how digital health can support integrated and person-centered care, especially for people with complex care needs, and how implementation and evaluation can help innovations become meaningful in real-world systems. Her work is especially important because it does not treat technology as an end in and of itself. Instead, it asks how digital tools can be designed, implemented, and evaluated in ways that improve care, support coordination, and reflect the values of patients, providers, teams, and systems. Carolyn, thank you so much for being here. We're thrilled to have you.
Yeah, it's so nice to be here and get to have this chat today.
Yeah. So your work really sits at the intersection of implementation science, digital health, and integrated care. What first drew you to that space?
Oh gosh, I mean, I think it's a really long journey. And when I talk about
You're
implementation
too young for a
sciences,
really long journey, just there. Yeah.
I mean, you say that. I've been around a while. And when I lecture on implementation science, one of the things I talk about is kind of like the history of what kind of gets you a lot of people to that space, because it's a discipline that requires, grounding in a lot of different kinds of disciplines that help us understand why change happens. We need to have some understanding of sociology and anthropology to understand culture change and cognitive psychology and behavior to understand why people change and political science to understand political systems. So my background actually started in like kinesiology and biomechanics around human behavior and change. And I did a minor in sociology. And then I went into political science. And then I went into organizational behavior and kind of political sociology, and then into technology. And through all of that, and then doing the work of actually trying to build a technology for patients with complex care needs and trying to put it into place, we came to seeing implementation science as a field that could be really helpful in understanding that kind of transformative work. And probably because I started with trying to understand complexity of patients, so people with not just multimorbidity, but a lot of social complexity. That means they tend to be in the system a lot and need the most care, and probably need the most care from a lot of different places. That's sort of where the integrated care space came. So a lot of things coalesced in kind of my postdoctoral work by just trying to build one little tool in one primary care space for one patient population where all of those three things really needed to coalesce in order to solve that problem.
So you mentioned so many different fields, and I always say how we just keep pulling from everything. What's the most recent fields or, different thing you've pulled from?
Oh, great question. So, as you know, I was just on a short sabbatical in the UK. So, one of the things I did was kind of go around to, six different universities, giving six different talks, and pulled from a lot of different disciplinary lenses to understand how people can come to respond to innovation in different ways, and what that means for us when we're trying to implement something, when we're trying to build something. So in each of those talks, I engaged in a lot of different theoretical lenses that have tried to understand how humans respond to new things and why they stay still or why they shift. And so I looked into, one talk was very much on cognitive psychology and social and cognitive sociology about individual change. Another one was very much about organizational sociology and understanding kind of innovation culture and organizations, why they shift and move. We pulled on institutional theories to unpack that. We spent some time with kind of like ethical values and moral sociology and moral panics and understanding kind of social responses to things like AI and why people are getting so very nervous and what that means to us from kind of like a moral, deep cultural standpoint at a more society lens. So it sort of depends on the problem we're trying to see and where we consider the biggest sticking point, which will kind of point me in the direction of which theoretical framework or grounding we think might be most helpful to us. Because sometimes the key sticking point for a change is a person and their frame of reference and their sense making about the challenge. And then you really need to dig into those more micro neurological kind of processes. sometimes it's like a social movement that you need to understand, and that's what's kind of getting in the way. And I think we're seeing a lot of that with some responses to AI in not just in healthcare, but in how research is responding to AI kind of infiltrating some of our methodology. And that's very much like a socially constructed view about what those things are. So it kind of depends for us, or at least for when me and my team think about it, is where do we think the biggest lever or the biggest thing getting in the way is, and where have, historical theories that have really tried to understand processes of change helped us to unpack what this means and what to do about it.
Okay, I'm going completely off script here because you're
Totally
saying so
fine.
much interesting stuff. So, has there been a time, let's say you've researched and used, organizational psychology, and then a couple years later, you're exploring a new field or a new theory, and then go back and say, you know what, that issue that we tackled or that digital tool that we implemented actually would be better served with what we're seeing now than as opposed to what we did 3 years ago. And what did you do in that situation?
Oh, totally. I mean, it's so evolving, right? I'm going to tell you, something we're working on exactly right now. In this conversation we had about some qualitative data, and actually we're looking at our full data set for a pragmatic trial that just completed in March. It's a very long trial. We got very delayed because of COVID. We were funded in 2019 and we're just wrapping up. And this was a technology we were co-redesigning to support patients with complex care needs transitioning from hospital to home. So I'm the NPA, or the principal applicant on that one, and it's co-led by Dr. Terrence Tang at Trillium Health Partners in Mississauga, and Dr. Michelle Nelson at Ottawa Hospital Research Institute. And lots of different things had been going on. And when we originally planned that project, we had pulled from things like the Consolidated Framework for Implementation Research, right? That's our standard one because it does all of the stuff, and it was a pragmatic trial. And we thought we might dig a little bit into something like normalization process theory, because that's one we had done before that had made sense. It was about how people normalize technology into their working lives and into their team structures. And we were talking about the data, and we had this very interesting challenge of running this trial across two different hospital networks that had very different environments kind of at play, which meant the technology itself looked in the end extremely different. One place took on the technology we had built, and the other one adapted their electronic medical record to have similar functionality. And then what ensued, what kind of led to and ensued, and what we were seeing from some of the qualitative analysis that the team and I were talking about yesterday, was not so much about people and teams integrating technology into their lives. It was so much about the organization's culture, about why things seemed to progress in the way that they did. So one of the things I learned about in my sabbatical, and one of the areas I've been trying to dig into, was around organizational like innovation culture. And there's a really interesting breadth of literature on that, like organizational learning culture, but innovation culture specifically, not just in healthcare, but broadly, that is kind of exploring how those cultures shift our adoption, openness, shifting of innovation, whether technological or otherwise. And so that's kind of a new lens that I think is much more helpful to us to unpack what all of the data we collected means. And it's not that something like CFR is no longer helpful to us. It's just that it's not telling us why things moved in a direction that or not. It tells us which factors are there, but not why things played out so very differently over these 4 or 5 years of this pragmatic trial in this example. So that's where I like to use kind of data, and where my kind of qualitative brain will point us in a direction of where theory might be helpful. So we're at the beginning of that journey, and I have a couple of theoretical frameworks we'll play with to see how that works alongside the inductive coding and things that we did. So that's one example, but that often happens. Sometimes our theoretical frameworks we start with carry all the way through, and they align. Normalization process theory, one that really resonates for technology, and we like a lot and seems to work in a lot of environments. But sometimes something different happens, and then a new kind of process emerges, and we need to go back into theoretical foundations to try to understand what happened.
Okay, so talking about implementing these digital tools in organizations, what do you think organizations, hospitals underestimate about the work of implementing these digital tools?
Yeah, gosh, well, they underestimate how theory can help, but well, that's a whole other conversation
Do they
about theory
even
to
estimate
practice.
that? Meaning, do they even think about that at all?
They don't, but I think this is actually related to what they do underestimate is they underestimate the time it takes to do sense-making work. And we've seen this in a lot of different projects that we've run, but also in lots of the literature as well, that when you're introducing something new, and whether it's theory or a technology or anything, you're coming at a person who has a particular like frame of reference for how they do their work and what is meaningful and valuable and what they're doing day to day with something that might not make any sense to them at all. If you're talking about theory, it's coming from a different worldview. If you're talking about an innovation, it comes from a different place of where it adds value, or a different person or a different team has kind of constructed what it means. And that gap of sense making is really hard to bridge. And, we have knowledge mobilization and translation tools and ways of going forward and things we can pull on, but it's often just time and understanding and humility and openness and some really gnarly things about human interactions that take just time and acclimation to each other. And sometimes we think, well, we're going to put this like change management process in place and we're going to do our good communication and we're going to push all of this information out and people will understand and off we go. But it misses a lot of the way we cognitively filter information. It misses a lot of the way how we construct interactions and all of these ways that kind of humans understand individually and socially that make that sense making work very hard and very time consuming, but very worthwhile. So when we've done some work understanding new processes or technologies, sometimes it's like an 18-month process, but at the end, everyone understands themselves and the problem and each other better. So they're able to do more challenging things as a team and collective.
It's always this push-pull because, I came from a very systems perspective. And if we change
Yeah,
systems, then but it really always comes down in the ends of the day to the individual. And if
yeah,
the
yeah,
individual, someone has to change their behavior somewhere along the way. And, we could
yeah.
support it, et cetera, but it's a process. It's not, okay, we put in this policy or we implemented this tool or, no, in the end of the day, if I'm not in, I'm not in. Me.
Totally. And recognizing those individuals don't exist in a vacuum. That's, I think, one of those challenging things that, well, a lot of behavioral scientists will love going to things like COM-B and things because they're like, well, the individual is the person who's changing. But my sociology background suggests that how the individual is socially constructed. Yes, there's individual traits and behaviors, but there's also team behaviors and there's also social behaviors and there's also organization. All those things influence what we do and what we think is valuable and what meaningful day to day. So there's the person and there's the interactional space. So trying to understand and appreciate the complexity of the person trying to change their behavior, and seeing them as part of a socio-technical web, is another challenge I think that we also underestimate. And that's where things like collective sense making and taking the time to do that can help us unpack that complexity and work with it instead of against it.
Right. So you spoke about the individual and the team and the system, but you also do a lot of international work, right?
Yeah.
So how do you see, are there stark differences within different countries that you work in that, you coming from Canada and you're like, oh my God, I can't believe they do it this way over there, or
It's so funny you say that because one of the things I pulled back, and I'm trying to reflect on this time away, is how we're facing so many of the exact same challenges. And the more you kind of dig at the underlying root causes, is that the root causes are the same. And so we can often look at our friends across an ocean or even across a border and say like, oh gosh, it's really working super well there. But the underlying root causes of challenges kind of remain really, really similar. The places where I see things being really starkly different, and not having systematically done this, but having kind of like reflected on their where they've come from and the conversations I've had with them, have very different kind of cultural approaches to things like technology. So I'm going to speak more on the technology adoption stuff because that's
yeah.
how I'm thinking about it. And my favorite example is Denmark. And I came to this and have chatted with many Danish colleagues around this, where I was there in Copenhagen for a conference and I had half a day. So I went and saw one of their, history museums. And it was one of their museums that talked about like where they had come as a country. And it talked about, when they started, they were like war torn for hundreds and hundreds of years. And what happened was, as a country, they're culturally had to be very collective and communal, that everything was shared and everything was about, protecting themselves, and everything was about, how can we work together for the social good of ourselves, for our kind of longevity and survival. And so that's kind of the story that I saw across this museum. And then when I thought about how they think about what technology is and digital health is, I'm like, oh, they think of it as a common good. It's not a private or held entity that private organizations can buy and sell, or a commodity. It is a public good. And they approach their policies around digital health and data as if it's a public good, as if it's like water or air, and they protect it and control it and maintain its ownership because of that kind of. And I saw the links between their historical culture and approach to what a public good is versus what a private commodity is, and then thought about Canada, and I thought about the US and other countries that have a very different kind of historical tradition around why things have kind of happened. And that's all my political science background, thinking
I was
through some of
thinking
that.
anthropology and
Yeah.
sociology more in terms of,
Yeah.
how they
Same thing,
evolved.
but a lot of policy analysis will take you down that same track. Like, what is our cultural background that leads us into?
Right.
And Canadians love this, right? Because as you know, like we talk about the difference between Quebec and BC and Ontario into these, which is a very anthropological kind of question around our policy histories. So where you see the big differences, I think, in the countries that I've talked to and had the opportunity to work with, have very different kind of cultural approaches and understanding the meaning making around what technology and digital health is, which means that they see different possibilities for what they can actually do with it, and will actually approach that implementation question differently. If you start from the same frame of reference, that it's, a commodity, it's to be owned, we're going to rely a bit more on private industry because of, neoliberal professional efficiencies and things like that. The policies and the way we approach it start kind of looking kind of the same. And the challenges we face are very similar. Um, the other big difference I'll see from one place to another is the level of homogeneity or heterogeneity of the population. So the broader the geography, the more difference in types of population you're trying to serve, that will have a really big influence on how things like technology get adopted and rolled out, and how infrastructures are built. Um, so, in Canada, it's such a bigger issue around managing kind of rural, remote populations, and what that means for equity and access is very different than my colleagues in the Netherlands that they were telling me, like, they got concerned when one hospital got closed, so now they'd have to drive 20 minutes to their closest hospital instead of 10 minutes to their closest hospital. And that was like a political nightmare. Meanwhile, we have communities that take 3 hours to fly out to their closest, medical center. So, those types of challenges can make things different around kind of geography and heterogeneity and managing lots of different kinds of user needs.
Wow. Okay. So we can't talk about, digital health without talking about AI, right? So
Yeah.
when evaluating AI and digital health, we can't, randomized trials don't always work. And but it worked in a demo doesn't, work either.
Yeah.
So how would we evaluate such a thing? And, what do you think is the most credible in terms of implementing AI?
Yeah, what a great question. I'm actually working with a wonderful colleague, Dr. Jeremy Petch here, who's one of the people who's run the only randomized clinical trial of AI in Canada. And
Oh,
actually, he was telling me that data is going to be coming out this year, and it's very promising. And we're trying to unpack that particular question around how we implement AI, and from like a socio-technical lens. So all the stuff I've been talking about, how do we think about all those things? And in thinking about that question, I actually did go back to see, how many, like, what is the state of the evidence on clinical trials of AI? And there was this review in 2024 that found 86, mostly in the US, mostly in China, mostly in radiology and cardiology. And I was, curious about what they were looking at, and, the usual suspects of randomized clinical trials. And, that evidence is really important. The challenge that you're suggesting to us, though, is in those lab environments, it's not able to collect things like the socio-technical environment in which they're going to be placed. And we know, AI is kind of a hotbed of trust issues and social constructions of what it means, and not just for people working in healthcare, but now globally and socially, that has a lot of meaning attached to it, which is going to shift the way people think about healthcare, and they think about their interactions when AI is involved in that team. So evaluations that we've always done have taken a socio-technical lens, which means we will rely on like lots of developmental evaluation approaches that sort of embed some things like design thinking. And we have a methodology paper I had co-written with my colleague, Dr. Jay Shaw, some time ago that talks about how we do this. But essentially, it's, for the trial component, or for if you're doing maybe an implementation effectiveness hybrid, you would do something like a pragmatic trial that's a little bit more open to a real world environment, and that should help you with the outcome measurement. The stuff I really like is when we embed things like ethnography into a trial like that and allow for adaptation in real world settings and consistent collection of data, both qualitatively and quantitatively, that allows us to adapt to our environment while also collecting process measures that help us understand why it's working and why it's not. I'm a big fan of, and the ethnographic method is kind of talked about by Greenhalgh and Swinglehurst back in 2010 as an appropriate approach to complex evaluation of technology. But I love sending teams in to observe, like just go and watch everybody work and watch when they're frustrated and ask them questions like, hey, how did you feel just now? Like clicking on that and tell me why. And it says so much more about how we construct our realities in these new technologically advanced spaces, where friction exists and where opportunity exists, that we can't always measure in traditional clinical trial ways, because recognizing these things as socio-technical products that not only integrate into our health, but will shape how we even think what health is, kind of requires a lot more thoughtfulness in how we collect that data and interpret and analyze as we go.
Okay. So we're out of time, but we like to end with a little bit of a tip for future students. So I have now, I think, two or three, but there's tons of students out there focusing on digital health, and they're excited, but they're wary about the hype about it. So
Mm-hmm.
meaning we're going forward. There's no stopping digital health, but what do you wish more people understood about how to evaluate it critically and, at the same time staying open to its incredible possibilities?
Mm-hmm. Well, I love kind of like critical optimism as a general approach towards like what we're going, like being very thoughtful about it, but still open to its opportunity. Um, Gosh, the thing I lecture on a lot about, and I wish folks understood more, is recognizing technology as a social artifact. And, we tend to lean on this as a technical, functional fix to a lot of things. And it does make people really uncomfortable to recognize that the phones in our pockets and the computers we're talking over are shaping our social environments and shaping who we are as humans. But if we ignore that discomfort and that feeling, then it's going to start holding a lot more power and shifting us in ways that we might not be happy with doing. So recognizing that it does hold quite a bit of social power, that it is, an artifact in the way that we interact with each other, is a really helpful starting point to be a critical optimist about where technology can take us.
So it sounds like, being open to new things, but being cautious.
Yes.
I love it.
Yes. It's
I
yep.
love it. Thank you, Carolyn. This was incredible, talking about theories, talking about AI, talking about pragmatic randomized control trials. It's all amazing. Thank you so much for your time. And I look forward to seeing what you're working on next.
Yeah, thanks so much for having me. It's really fun.